So good morning, everyone. Thanks for having me. Next slide, please. Yes, I mean, listening to the other talk, comorbidities contribute significantly to maternal deaths. And from 2015, next slide, please. Yes, and 2016, next slide. And as recently as 2022 Embrace report, 52% of maternal deaths also was due to pre-existing conditions, and earlier on about 59%. So we can see that comorbidities still play a very, very major role in maternal deaths. Next slide. Yes, and the fact is, it's a long list of chronic conditions, like this stack of books, ranging from the very simple to the complex and sometimes even the very complicated scenario. Next slide. But across all this spectrum, what runs through is the MDT, the medications the woman is on, or perhaps have to be considered. Diagnostics, the care plan, and also communication. So whether it's a simple medical condition or complex or complicated, these are the four key considerations. Next slide. So with the MDT, the team assess the interaction. From that, they're able to define the health status of the woman, define prognosis, all of which become quite useful in counseling and management. Next slide. Yeah, the interaction, this is the conventional, interaction, how the pregnancy itself will affect the medical condition in terms of clinical course and some also the drugs. I was listening to the other course and some mention was made of this, and how the medical condition will affect the pregnancy. So fasalazine, for example, which is used in treating some of the connective tissue disorders and GIT disorders, is anti-folate. So if a woman is on it, we have to make sure that at least she's on high folate. And metformin, commonly used in treating diabetes, also is an anti-folate. And for women who are prescribed prolonged low molecular weight heparin, we have to understand that it can cause osteopenia. So vitamin D supplementation should be emphasized. Next slide. Yeah, so from the interaction, we get a full range of information, ranging from recognizing the potential issues from which we are able to identify the appropriate MDT to produce a care plan which should be communicated to all parties involved. The care plan should cover antenatal period, intrapartum, as well as the postpartum. I was listening to the other talk, and there was this talk about low molecular weight heparin prescription, and that sometimes there isn't a care plan. It's important that a care plan is in place for the management of the woman. Next slide. Medications issues are safety, and both during the pregnancy and also with breastfeeding, and all these have to be discussed with the woman. Next slide. Diagnostics, yeah, if you suspect a woman might be needing some imaging, so we have to be thinking about whether the contrast is safe for her to have that particular imaging. They always have to sign a consent if they're having a CT and MRI. We have to be thinking of the reliability of the results. ESR, which is often requested outside pregnancy, isn't as useful in pregnancy. Prolactin levels go up in pregnancy, so it's not also useful, and so is thyroglobulin. The interpretation of results, full blood count, there's hemodilution, so the reference ranges for anemia is different from the non-pregnant, and I also use interpretation of urea and electrolytes and thyroid function test is also different. So it's also important to appreciate the differences that exist between the pregnant and the non-pregnant woman so that the right decisions are made to guide management. Next slide. Yeah, the care plan, as I should cover the antenatal period, labor and delivery. So antepartum omission of low molecular weight heparin, and also prescribing hydrocortisone for women on prolonged steroids, all should be clear, in the care plans. Postnatally, some drugs prescriptions have to be reduced. For example, if an active woman, a woman with underactive thyroid had an increase in thyroxine, postnatal reduction have to be considered. And the same goes for the anti-epileptic drugs that are used, are increased during the pregnancy. Next slide. Yeah, so we go through cardiovascular disorders. It's just a list. Chronic hypertension is pretty common. We also seen some ladies with posterior orthostatic tachycardia syndrome. Occasionally we see women with cardiomyopathy, and they often refer to the tertiary level for further management. The network has produced a clear care pathway for a lot of these conditions that we're going to look at. Next slide. Yes, so for the cardiovascular disorder, the main considerations are the MDT, the professional team will assess the woman's physical status, be able to give an idea of the mortality risk. And of the common investigations is you have the ECG, which could just be the standard 12 lead. Sometimes they need an ambulatory monitoring, for example, those with palpitations. This could be 24 hours up to 72 hours. If they need BP monitoring as well as ECG, that's referred to as the Holter monitoring. Sometimes it's an event monitoring, sometimes ambulatory BP. Sometimes they require an echo. And for palpitations in particular, it's also useful to request electrolytes. We also will have to look at some of the drugs that they are prescribed. Some might have to be removed during the course of the pregnancy. Next slide. Yeah, the whole experience of adaptation to cardiovascular physiology borders on what happens in with the cardiac output. You can see that from early gestation, even around 13 weeks, cardiac output is 20% above baseline, increasing to about 40% by 28 weeks, which is maintained till 40 weeks. Intrapartum goes up to 60. Shortly after delivery is up to 80, and an hour later is 60. The key thing is that a lot of the presentation is in the postnatal period. I quite remember when I was a registrar, one African lady had to end her pregnancy around 20 weeks because of fetal anomaly. As soon as she delivered, she became cynosed, and an echocardiogram showed that she had abnormal heart valves. All her heart valves were abnormal. I personally did the cesarean section on a woman with minimal blood loss. After delivery, she dropped her blood pressure. She was given a lot of fluids, developed pulmonary edema, and an echocardiogram showed that she had mitral stenosis. So that's the reason why the cardiac output that sort of increased shortly after delivery. All that it means is that if women have some red flags antenatally, it's very, very important that they are investigated rather than being left to the postnatal period. Next slide. So this is an example of a woman who was, again, another tab. This is a woman who was 40 years old, third pregnancy. She smoked and she had a stent. She had had a coronary heart disease, had a stent. So at the time she was seen at 9 weeks, she had already completed her course of clopidogrel. She was on aspirin, atenolol, ACE inhibitors, and statins. These two drugs were stopped when she was seen. And in actual fact, at 9 weeks, she wasn't sure whether she was going to continue her pregnancy or not. So I arranged the viability scan, saw her in a week's time, and she said she was going to carry on. So of course, her management involved the cardiologist and anesthetic team, and she had a vaginal delivery at 39 weeks. Next slide. So in assessing, cardiac status, I think you might all have come across this New York Heart Association functional classification. If you are breathless at rest, then it means you have quite a severe cardiac issue. Next slide. And this is the modified WHO classification of maternal cardiovascular risk. And the class 4 gives a list of conditions for which pregnancy is contra indicated. Sometimes we see women who already be pregnant and so become quite a challenge. These are when I started talking of the complex and sometimes complicated women. I came across a lady who was had malfunction with an aortic dilatation of 4.3 millimeters, 43 millimeters on an echo done 2 years previously. She transferred to us very, very late, I think around 40 weeks. And she was in labor when we realized that particular report. She was already nearly 4 centimeters dilated. We delivered her by emergency section. Reluctantly, she agreed to have the operation because she hadn't had any counseling prior to that. But it's all important that this kind of information is picked up early and acted on at the right time. The medics also got involved and prescribed bisoprolol for her the following morning. The anesthetist it was in the night, and the anesthetist had to call her consultant also for some advice. So if she had been seen much earlier in the pregnancy, I'm very sure there would have been a clear plan of care. But anyway, subsequently, she was cared for. The medics took over her care afterwards. Next slide. So from the point of hematology, anemia we see very commonly, but one particular feature of anemia is the non-anemic iron deficiency. Once a midwife said to me, she's got a patient with normal HB but low ferritin, and her GP wouldn't prescribe oral iron for her, but it does exist. We have hemoglobinopathies, the sickle cell disease, as well as the carriers and the thalassemias. We have the bleeding disorders. We have the thrombocythemia, which could be either essential or secondary. One feature of secondary thrombocythemia is that it does not predispose to thromboembolism unless the woman herself has an inherent predisposition. But essential thrombocythemia predisposes to blood clots. We have the thrombophilias and the antithrombotic deficiency, even if a carrier requires thromboprophylaxis right from the beginning of pregnancy. With regard to the other factors, it's only when they are homozygous or there's a combined defect, that is factor V Leiden mutation heterozygous with protein C deficiency heterozygous or prothrombin gene mutation heterozygous. Those are the ones that, but in all these instances, the MDT will assess and make a decision on the way to go with her in terms of thromboprophylaxis. Next slide. So the MDT, as I said, will assess, they will assess VT risk. There's a low threshold to investigate and treat for suspected VT, and the timing of low molecular weight heparin should always be explained to the woman. Those on prophylactic medication require a 12-hour gap between injection and the siting of a regional analgesia, whilst those on therapeutic regime require at least 24 hours. What is also important is that women on on quite a prolonged prescription of low molecular weight heparin are given some vitamin D for bone protection. I mean, it's quite a recommendation that every pregnant woman takes at least 1,000 international units. So we have to be ensure that at least they are on that kind of prescription. Next slide. So this, because of dilution, as I said, the figures for defined anemia in pregnancy is different from the non-pregnant. So in the first trimester, it's 110 grams per liter, dropping to 105 in the second and third trimesters, and the postpartum less than 100. Next slide. So regard platelets, non-pregnant woman 150 to 400. If it's with it, most of the time it's also within the same range for the non-pregnant woman. But you define a pregnant woman as having thrombocytopenia when her level is less than 100, because 10% of pregnant women will drop their platelet count, and that's referred to as gestational thrombocytopenia. White cell count does increase in pregnancy. That's why it's not as reliable. And this in assessing inflammatory processes, and this all comes from the diagnostics I mentioned earlier. CRP is, however, maintained and is quite useful test when we are assessing for inflammatory and infections. Ferritin, if level is less than 12, then she's obviously highly deficient and treatment is required. The British Hematology Association defines iron deficiency in pregnancy as being less than 30. And if the level is less than 50, it's advisable to start supplementation because it's obviously going to reduce further. Next slide, please. Yeah, I mean, anemia is commonly classed as microcytic, that is the cells being small, being of normal size, normal color and normal size, or being quite big. So the cause of macrocytic anemia, B12 deficiency, folate deficiency, copper deficiency, vitamin C. Iron deficiency anemia is the commonest cause of microcytic anemia. But the fact is, when you have iron deficiency as well as folate and B12, you will likely to have a nomocytic, chromic picture. The thalassemias and then the other hemoglobinopathies also present with microcytic anemia. Here, the nomocytic pneumochromic, the other causes are kidney disease. It's just because they affect the erythropoietin effect is reduced, and also as well as its production because the kidney produces erythropoietin, which is the main hormone responsible for red blood cell production. With underactive thyroid, underactive thyroid could also present with anemia, and it's all because of a poor marrow response to erythropoietin. And with protein depletion, it's a similar mechanism. Next slide. So this there's an example of a woman who had both folate and iron deficiency. She was initially on iron prescription from 28 weeks, and it was at 35 weeks that she was prescribed folic acid, and 4 weeks later her HB had improved. Next slide. Yeah, and this is an example of a woman on who had B12 deficiency as well as iron deficiency, and was also on a prescription of iron initially. At 34 weeks, she was prescribed some vitamin B12, that's hydroxycobalamin, just 1 milligrams, and then repeat HB 6 weeks later, and HB was better. So initially iron is not helping, that is after, usually when you start the iron prescription, you check HB in 4 weeks. It depends. That's if it's early in the pregnancy. In the latter stage, maybe you check in 2 weeks. The increment is 20 grams per liter in 4 weeks. That's the increment. It's 20 grams per liter in 4 weeks. So knowing that, you'll be able to judge whether the increment is optimum or not. Next slide. Tap again. Tap again. So this is the lady with non-anemic iron deficiency, HB normal, but her ferritin was less than 4, and her symptom was tiredness. Next slide. So inflammatory bowel disease, a whole host of them, but we'll be talking more about ulcerative colitis and Crohn's. Next slide. So with the main considerations here, whether the condition is immune or non-immune. Example of immune ones being celiac disease, pernicious anemia, whether she's had surgery, all of which have implications for childbirth, and of course, being gastrointestinal, nutrition has to be considered. And then it's important how the liver function test is interpreted. It needn't be interpreted in isolation, because you could have a normal enzyme levels, but with very abnormal clotting or high bilirubin. So it's always important that the enzymes result is interpreted within the context of the bilirubin level and or clotting. Next slide. So the main considerations are to explore the disease activity, the drugs. Of now, a lot of the women are being prescribed the biologics, and some are using very modern ones referred to as the pegylated types, which they are able to carry on throughout the pregnancy. Otherwise, the conventional ones like infliximab, they usually have to stop around 35 weeks. But you have to talk to the woman. She would have had a word with her doctors and given appropriate advice as to how to proceed with them in the pregnancy. You have to know whether they've had any surgical procedures, and some of the investigations that one would have to request. We tend to request fecal protecting to give an idea of disease activity. We have to do a VT assessment, for which if disease is active, we prescribe dactaparin from the beginning of the pregnancy or from 28 weeks, depending on the level of risk factors. And of course, we also monitor babies' growth with serial growth scans. Next slide. So with Crohn's disease, it could affect the ileum, and or colon. With the ileum, what it would then affect is absorption of B12 from the terminal ileum. The colon, bacteria in the colon produces some vitamin K. So diseases involving the colon would also affect that bacterial contribution. So this is what one should bear in mind. Regarding flare-up, Crohn's tends to flare up within the first trimester and after birth, whilst ulcerative colitis usually will flare up in the first and second trimesters, remitting in the postnatal period. So this is some information that you can share with the woman when you meet them. Next slide, please. So with celiac disease, I mean, you have to also assess their disease activity. Majority of women with celiac disease that we see here are in remission because they will be on the gluten-free diet. But the disease, which is immune in nature, tends to affect the intestine, the main areas being the duodenum and upper jejunum. And these are also the sites for the absorption of iron and folic acid. So if she's got malabsorption then in fact these vitamins, the levels will be reduced. And it's an autoimmune condition, so you have to be thinking of some other concurrent autoimmune disorders, particularly underactive thyroid. Next slide. So investigations that we tend to request is bone chemistry, because celiac disease is a cause of osteoporosis. We request hematinics because it's also a cause of low ferritin, low folate, as well as low B12. And we also check their vitamin D just to make sure that if she's got low calcium, it's not because of a low vitamin D status. And because of the it's been an autoimmune condition. We want to also exclude that she's not got concurrent underactive thyroid. Then we also will check her clotting screen, because celiac disease is a cause of steatorrhea, meaning that she will not be absorbing her fat-soluble vitamins, of which one key one is vitamin K, which induces the production of uh, clotting factors 5, 7, 9, and 10. So it's also a test to consider. And we screen for gestational diabetes as well. Next slide. For women who've had bariatric surgery, nutritional deficits are what should be considered. And at the Royal Surrey, we have a bariatric panel of a long list of tests. So we just request that on our center, on our electronic system, and it's done. Their screening for gestational diabetes should be modified. They are not suitable for the traditional oral glucose tolerance test. That leads to what we call dumping syndrome. A lot of sugar enter their intestine. It's promptly absorbed. Insulin level goes up and pushes it down to hypoglycemic state, and they can become very dizzy. So profiling rather is recommended. Next slide, please. So move on to endocrine. The key thing about endocrine is knowing whether it's an isolated condition or part of what we call a polyglandular deficiency syndrome or multiple endocrine neoplasia. Next slide. So here the main others are diabetes. Here it's important to establish whether it's a type 1 or a type 2. If a type 1, sorry, you have to exclude other endocrine conditions like underactive thyroid, and the reason will become obvious pretty soon. And also eye tests should be asked inquired about, just to make sure they've had their eyes examination, and they need a renal function test just to rule out diabetic nephropathy. So other conditions, thyroid disorders, and porphyria, which is a metabolic condition. Here, the main issue relates to restriction of drug prescription, because some drugs, even iron administration, can precipitate porphyria presentation. So that's the main thing to know about porphyria. But they often are aware of their condition and will have a list. What we do here is to ask pharmacy to give us an updated list of any prohibited drugs. Next slide. Yes, so the polyglandular deficiency syndrome, what we often come across is the type 3, where we have thyroid disease, pernicious anemia, diabetes, celiac disease, myasthenia gravis, and vitiligo. So that's why here, every woman with celiac disease that we see in clinic, we do a thyroid function test. If we have a woman with pernicious anemia, we will do a thyroid function test. I've come across women with SLE, with underactive thyroid, rheumatoid arthritis with underactive thyroid. We don't go digging for everything, but we know that the thyroid hormone is essential for babies' brain development. That's why we focus so much on it. Next slide. So with the men's here to the import, you don't have to know everything in detail, but just to know that, for example, if a woman has had thyroid surgery, you'll be interested in knowing the type. If she should then have maybe raised blood pressure during the course of pregnancy, it becomes easy to understand why she's got raised blood pressure. Could it be because of pheochromocytoma or just ordinary blood pressure? Next slide. So the thyroid disorders, you have underactive thyroid, subclinical. Postpartum thyroiditis usually presents around 3 months post natally. It's often a retrospective diagnosis, often present initially as overactive thyroid, and the woman prescribed anti-thyroid drugs, and a few months down the line, be prescribed replacement therapy, that's thyroxine. Next slide, please. So the main considerations with regard to underactive thyroid is the cause of the underactive thyroid. We also have to know whether she's on optimum replacement and postnatal drug plan. That's a hair care plan. There should be a postnatal plan for that. Next slide, please. Tap again, please. Again, again, again. Yeah, again. So the causes, the main is Hashimoto's, but it could follow treatment for overactive thyroid. It could follow treatment for postpartum thyroiditis. Next slide. Yes, so the reason why you have to know the underlying cause, if it's Hashimoto's, it's autoimmune, screen for gestational diabetes. If she's treated for Graves' disease, you screen for gestational diabetes, check her thyroid stimulating antibody status, because persistence of the enzyme, particularly in the third trimester, predisposes to neonatal thyroid toxicosis. We found out if she's been treated for thyroid cancer, and as I mentioned before, you think of whether she could have other malignant issues. So she should have blood pressure, you know what to be looking for. And the woman also requires suppressive dose of levothyroxine. You push the TSH level to less than 0.03, thereabout. This is not where her TSH should just be less than just 1.5 and all that. She needs suppressive dose of levothyroxine. I once had a lady with a TSH of 7, and I advised her to increase her levothyroxine. And she said to me, her cancer doctor said it's fine. I explained to her why. And before later on, another colleague saw her and gave her similar advice before she increased her dose of levothyroxine. So postpartum thyroiditis, autoimmune skin for gestational diabetes. Sometimes the cause is unknown, but as I said, Hashimoto's is common, so probably it will be an Hashimoto's. The test to do is the thyroid peroxidase antibodies. It peaks around 14 weeks of gestation, so you have to interpret the result accordingly. Next slide. So underactive thyroid, optimize replacement, ideally preconception and antenatally, you establish the underlying cause. As I mentioned earlier, you request thyroid function test. You just need a TSH and free T4, no need for the free T3 unless you're looking for overactive thyroid. And then you have to know, inquire more about her levothyroxine prescription. Has it ever been increased recently? If not, it's recommended that it could be increased by 25 micrograms. And at the same sitting, could have a thyroid function test because she doesn't have any thyroid function test result. And whenever level medication is increased or changed, you repeat the test in 4 weeks, not less than that, because the change in the TSH lags a bit behind the increase in the free T4. So doing it 4 weeks, less than 4 weeks, doesn't give the true result. So ideally, 4 to 6 weeks is recommended. Next slide. So if thyroxine is increased in pregnancy, you revert to pre-pregnancy dose and repeat the thyroid function test in 6 weeks. I always say this with some exemptions. Supposing a woman's first thyroid function test, I said 10 weeks, and the TSH is say 7, starting on a levothyroxine prescription of 50, and then during the course of the pregnancy, it's increased up to 150. I don't think it would be reasonable to revert to 50. It means 7 at 10 weeks meant that she wasn't on optimum treatment. And there is studies to suggest that a good proportion of women who require increase in pregnancy were initially not on adequate treatment. So here probably you'll be aiming to maybe drop her down to about 100 and have a repeat thyroid function test in 6. So this is all just something to bear in mind. There's a guideline, but you have to know how to work around it. Next slide, please. So of the overactive thyroid, the commonest is Graves' disease. Next slide. And the main considerations regarding that is the drug effect on the mom and baby, if consideration for lactation, and because of the risk of neonatal thyrotoxicosis, we always have to involve the peds as part of the MDT. Next slide, please. So with regard to the medications, the common ones are propyltyrosol and carbimazole. They all can cause what is referred to as agranulocytosis, that's leading to neutropenia. The commonest presentation is sore throat. So always ask these women whether they have any sore throat. Carbimazole can cause some congenital anomalies, that's esophageal and choanal atresia and loss of hair, and absence of hair on the head. So that should also, the woman, if she's on it, should be informed about that. And rarely, PTU can cause liver issues. So a baseline renal liver function test is advisable. Next slide. With rheumatoid consideration, a whole host of them. What we commonly see is rheumatoid arthritis and SLE, often in remission. What is important, always ask them about whether they've had blood tests, and you want to know their ENA status. We'll talk more about that later on. We also do see women with renals, often within the context of renal disease or Reynolds phenomena. The key thing is here, the Reynolds phenomenon could be due to other causes, which include connective tissue disorders. And I once had a lady who was 36 years old, about 16 weeks pregnant, coming with to clinic and saw that she had this Reynolds phenomena in her medical history. Father has a history of scleroderma. She had never been tested, had an autoimmune screen, and when she agreed to have one, she had multiple autoimmune antibodies. So whenever they present, we have to ask about that and do some tests. Yeah. With Marfan's, we don't see them often here, but of course, if you have to do an echo, so with LS-Down loss, we see patients with scoliosis very often, and anesthetists have to assess them. So with lordosis and kyphosis. Next slide. So the general consideration that once again, the MDT, assess their risk of blood clot, establish their ENA status, screen for diabetes, underactive thyroid, monitor their blood pressure, and also review their prescription. Next slide. So thrombotic risk once again, transfer of antibodies. The raw antibody in SL, you find it in SLE, Sjogren's, rheumatoid arthritis, and mixed connective tissue. And when present, 2% of babies could have there's a 2% risk of congenital heart block. We have to review their steroids. Potentially that could cause adrenal suppression. So as part of their plan, you highlight that if admitted with any acute condition, in any acute scenario or at the time of delivery, cesarean section, they need cover with IV hydrocortisone. This should be in the care plan. We screen for gestational diabetes, but not with oral GTT, but with BM profiling, rather than oral glucose tolerance test. We review their immunosuppressants and make an appropriate care plan with that. And we have to exclude other autoimmune associations. Next slide. So it says disease activity, exclude other associated causes, complications, particularly renal dysfunction. Presence of renal involvement in rheumatic conditions is very bad prognosis. We monitor mother and baby. Next slide. So in assessing this activity for SLE, you check their anti-double-stranded DNA and complement 3 and 4. That's what we do commonly here. And we send urine for sediment. Risk of thromboembolism is assessed with the beta-2-glycoprotein. And risk of congenital block, we always will check for their ENA antibodies. If positive, we organize a fetal echo, which can pick up the third-degree heart block. In the absence of that, we request a neonatal ECG, which can help pick up a first and second-degree heart block. Next slide. So kidney disorders, a whole host of them, we tend to see those with a recurrent kidney disease. Next slide. So creatinine level is used for definition, and the EGFR is useful in prescribing their medications. Next slide. Next slide. Okay, so for some women, pregnancy is contraindicated, those with severe moderate impairment, and those with risk of renal deterioration. And creatinine, as I mentioned, is used in classifying the condition. Next slide. So recurrent UTI means 2 UTIs in 6 months or 3 in 12 months. Pregnancy is often over, it's in general, I mean, that's a 9-month duration, so we will take the 6 months. Next slide. So imaging, that's ultrasound, safe for the mom, so has to be reassured. We treat the infection, and once urine is clear at a subsequent test, we give antibiotic prophylaxis. Usually we prescribe here cephalexin 250 milligrams at night, and this is continued till 4 weeks because it's postnatally. It takes a bit of time for the structural changes within the renal tract to resolve. So we continue the antibiotics over a 4-week period, and that is in the plan. If the imaging should show any anomalies or for which postnatal imaging is required, we put it in the care plan as well. Next, and we do the imaging, repeat imaging around 8 weeks. Next slide. Asthma, PE, and bronchiectasis, main respiratory issues. Next slide. General considerations, particular imaging comes to the fore. Next slide. Asthma, most women tend to omit their medication for fear of its effect on the baby, but they have to be reassured that they're safe to have. Next slide. Next slide. Yes, press again. Yeah, so next slide. Yeah, so we have to be reassured that it's safe. Medications have to be avoided. That some medications to help control postpartum hemorrhage, which are the carboprost and ergometry, and also non-steroidals have to be avoided. Next slide. Epilepsy, commonest neurological condition. We see multiple sclerosis often in remission, and quite recently we have seen a lady with hydrocephalus with a shunt, which we refer to the MDT. Next slide. So with neurology, one of the main issues regards imaging, for which mother has to be reassured of its safety and benefits. Next slide, please. So with epilepsy, we always have to know the type of epilepsy they've got, their last neuro review, and their prescription. Next slide, please. Support at home and work, yeah, and a clear plan of care for the post. We have to make them aware of SUDEP, that is sudden unexplained death in pregnancy. Fortunately, next slide, fortunately, there are modifiable factors. Next slide, please. Fortunately, there are modifiable factors which they have to be made aware of. Sleeping alone, for example, without supervision is one factor that can be modified. And we have to encourage compliance with their medication and omission of alcohol and drug misuse. Next slide, please. Those with tonic-clonic seizures are predisposed to SUDEP, and so are those with focal seizures. Next slide, please. Next slide. Yeah. So it's important to know what medications they are on. Monotherapy has a less risk of congenital anomalies, but those on multiple therapy are higher risk. And if it includes valproate, the risk is even higher. Next slide. And that is why sodium valproate is not recommended for any woman in reproductive age because of the very high risk of congenital anomalies. Next slide. Next slide. So joint care with the neuro team, anesthetic involvement, aim for monotherapy, avoid sodium valproate. Next slide. And peripartum plan should be clear. They have to avoid pethidine. And we now have a woman who is on clobazam prescribed by her neuro consultant. And postnatally, following delivery, a clear discussion regarding risk of seizures, talk about contraception, and encourage SUDAP awareness. Next slide. So mental health issues also pretty prevalent and a cause of maternal death. We always have to support these women to go through their very difficult situation. Once I had a lady who, in spite of all support and all that, and even being in the mother and child care unit postnatally, still committed suicide. So they need a lot of support. Next slide. So the support that they need, both within community and by the healthcare personnel, we always have to look at whether they have any comorbidities, because drug interactions could be the reasons why they're not recovering or doing so well. Next slide. Next slide, please. Next slide. So postnatally, there could be issues, and the woman has to be, informed about the potential risk of all these postnatal issues. That's why they need all the support from the healthcare staff and also community-based network to give her all the support she needs. Next slide. Next slide. Yeah, we see women who are sort of misusing drugs, and they also need support. We want to know what care plan they have regarding stopping drug misuse and also withdrawal plans. We have to communicate quite early in the pregnancy with our neonatal team, making them aware that that is going to happen, and there should be a clear postnatal plan as well. I think this is the last slide. Next slide. Any questions? I had to run through, but I made it a lengthy slide so that in your own spare time, you can look through them.
Thank you, Matthew. That's great. We got loads of questions while you were talking.
Okay.
So what I was thinking is, in the interest of time, there's quite a few on there that I can answer myself, but I thought I'll ask you a couple of the ones that I can't, and then I'll go through the questions during the break and answer the ones that I can. But the first one was, what is the pathway for women who have a normal HB but a low ferritin of 12 or less?
Come again.
So what is the pathway for women who have a normal HB, a normal hemoglobin, but have a ferritin of 12 or less?
Oh, I mean, the fact is that it's always good, it's always important that you take the history, because you want to know that they don't have any dietary issues, or gastrointestinal issues. Celiac disease is a cause of underactive thyroid is a cause of low ferritin. Celiac disease is a cause of low ferritin. You understand? So you just have to make sure that she doesn't have any suspicious presentation. Excluding that, you can then prescribe oral iron, okay, to bring it. Often within 2 weeks, they begin, if it's tiredness, they begin to improve. Yes, but I would check their folate and B12 as well. You understand? Because folate deficiency will affect the lining of the gut. If you have a healthy gut, you absorb your iron, and folate is required for regeneration of gastrointestinal villi. Yeah, so if the villi is not healthy, you're not going to absorb well. So you just have to make sure that there's no coexisting folate or B12 deficiency. Yeah, yes. So that, and
Perfect.
I
Thank
have a
you.
lady actually. I have a lady actually who just a few weeks ago it was the same. Her ferritin was 14, folate was low, B12 was normal. We gave her folic acid, asked her to stop her oral iron 1 week, take only folic acid 1 week, and then resume. She had a blood test 4 weeks later. Her ferritin had moved from 14 to 53. Just, ferritin has moved from 14 to 53 with folic acid, and then later resuming her iron. Yeah, yeah.
Thank you. And then the last question for you is also about anemia. I'm going to paraphrase the question, but essentially it's how long would you wait to offer an iron transfusion, an IV iron transfusion on somebody that, after starting oral iron on a woman who has an HB of 76 at 33 weeks and also is a sickle cell
76 at
carrier.
33 weeks. And
Yeah.
what? And
And
what?
she's also a sickle cell carrier.
Okay. The key thing is that what you said her ferritin is low.
They haven't said her ferritin. They've just said
Yes,
hemoglobin of 76. Oh, no, sorry. Her
yes.
ferritin is low. Her ferritin is 8. Yes.
Ferritin, okay. If ferritin is 8, then of course she's iron deficient. But then I always say that what is her B12 and folate as well? You understand? Yes. Because I mean, anyway, at that late around this gestation, you'll be thinking, oh, she needs the iron infusion straight away. But there are only two indications for iron infusion: poor compliance and malabsorption. These are the only two indications for iron infusion. The low ferritin simply means that the store is low. So when the iron HB gets to a normal level, you then carry on taking iron for 3 months to replenish the store. So I say to the pregnant woman with low ferritin, after your delivery, because you're going to lose some blood, continue taking iron for 3 months. So the ferritin is only a marker of iron store. It's not an indication that you should have iron infusion. But if the woman is not complying or has malabsorption, that's why you check in about 4 weeks, but making sure that she's complying. In that situation, is her folate level also normal and her B12 normal. If I should quickly say, once a midwife referred a patient whose HB was low, HB was around 9, and her ferritin was also low. We checked her folic acid and B12. Her folate was less than 2. She was at this time around 35 weeks. So I said to the midwife, we give her some folic acid, recheck HB in 2 weeks. When we rechecked her HB in 2 weeks, it was more than 10. She carried on with iron. We added folic acid. HB was more than 10. So we didn't give her iron infusion. You understand? Because the
Yeah.
fact is that you need iron, folic acid, and B12 to build a heme ring of hemoglobin. So if you give her iron alone and she's not sufficient in folic acid and B12, she's not going to build a heme ring. So you always have to make sure that ferritin is low, but what about her ferrit, folate, and B12 level as well, which you then have to correct. And often if you correct those, you have time to correct those, there's no need for pharyngeal.
Thank
Yes.
you. Brilliant. So the other questions that we've had, I think I can give the answer to, so I'll type them
Okay.
up in the break. We're going to take
Okay.
a 10-minute break now before we
Okay.
come back. And Kate, we have a talk with Kate. So thank you, everybody.
Thank
We
you
will
very
see
much.
you in 10 minutes. Thank you, Matthew.
Thanks. Okay.